Two fantastic lectures on oscillometry. So while we the most I've been like using oscillometry and FeNO also for quite some time now. So most important thing about lung function test, if you compare ourselves with cardiologists, there are two main differences about lung function test and ECG and echo. The first is, unlike ECG, which can give you a diagnosis, lung function test can suggest patterns. You cannot like diagnose a particular disease most of the time. It can suggest patterns. So it will give you insights about the physiology. And if you look at the ERS guidelines, that is what they've changed to. Instead of diagnosing a disease, you only now diagnose abnormal physiology based on lung function tests. So that is the single most important difference compared to what the cardiologists do with their testing. The second important difference is it's not done at all. So that is so if you go to a cardiology OPD, you will not find anybody without an ECG. But if you go to the pulmonary function lab, the pulmonology OPD, you'll find almost nobody has a PFT. So we need to change that in terms of culture. We need to not only listen to patient symptoms, but we need to do more testing on our patients to make more evidence-based diagnosis. We've had like good talks in which we've known like how oscillometry now is a new tool which gives different facets more information than conventional spirometry. Now we'll speak about the third piece of the puzzle and FeNO. And for this, mostly I'll be focusing on asthma. Towards the end, a couple of other newer developments with FeNO and other diseases. So to begin with, what is this FeNO? What is the biology of fractional exhale nitric oxide? So nitric oxide is kind of a universal molecule. And then when it was, discovered, it then very quickly won the science molecule of the year in 92, and then a Nobel Prize for medicine also in the end of the decade. So a lot of interest in nitric oxide about 20 years ago now. And over the last 20 years, we know that now it's a good, it plays an important role as a vasodilator, as a bronchodilator, as a neurotransmitter in the airway in the non-sympathomimic, non-parasympathetic pathway. It also has a lot of immunological roles in terms of as a mediator in inflammation, and it also plays a large role in the development of the fetal development of the lung. So the nitric oxide that is there in the body, can be generated by an enzymatic pathway or a non-enzymatic pathway. Focusing on the enzymatic pathway, that is predominantly by the iNOS protein, the NOS protein synthase, and that usually uses L-arginine as the substrate. There is a constitutive low-level production of NOS, which is important for endothelial vasodilatation and neurotransmission. But what we are actually, for purposes of this talk, focusing on is the inducible iNOS, which is one which produces large amount of nitric oxide and is called into play during active inflammation. Of course, a neuronal NOS is also abnormal in patients with asthma. So these are the three components to production of iNOS. There is also, like I said, non-enzymatic production of nitric oxide synthase, that is by from when there's a lot of irritation in the airway and due to a lot of airway pollutions which can contain nitrous oxide and sulfur dioxide, etc., and that can be broken down into nitrite. The nitrate can be broken down to nitrate, which can release quickly be reduced to nitric oxide. So that is something again which you have to implement, and all of these are important when you interpret FeNO. So this constitutive iNOS in normal epithelial cells, there is a very small level of nitric oxide that will be picked up in the airway, and that plays a small role in airway maintenance, endothelial maintenance, and neuronal transmission. As opposed to that, when there is inflammation, and this is predominantly driven by interleukin 4 and interleukin 13, and I wanted to focus on those two molecules for a moment here. You have a higher level of nitric oxide coming across the airway epithelium. So this is what I want to focus on. So the airway inflammation in asthma is pretty heterogeneous. Overall, we broadly kind of lumped it into T2 high and T2 low. And what used to be earlier recognized as TH2 high and TH2 low has now changed to T2 high and T2 low, because we know that apart from the T helper 2 cells, there are other cells which participate in the T2 type of inflammation. This is primarily the innate lymphocyte, ICLs, innate lymphocytes, which can also generate all these molecules. And drive the type 2 inflammation up in patients with asthma. So overall, in the type 2 inflammation, we have three main interleukins which are driving it, mainly 4, 5, and 13. Of this, the interleukin 4, 5 are primarily driving the eosinophilic inflammation, whereas 4 and 13, which actually share a alpha chain, primarily drive the FeNO up. So these are actually related, but not necessarily happening in all the patients all the time. So this is important when you interpret FeNO. So the question is now, how do we measure FeNO? So there are three main techniques in which FeNO has been measured since the time there has been recognition of elevated nitric oxide in the airway. The first and very earlier technique used to be the chemiluminescence, which is the reference technique. For example, even now, ATS recommends chemiluminescence when you want to measure nasal nitric oxide. However, the problem with chemiluminescence is that the machine is is huge. It's 40 kilos, hard to move around, and it costs a lot and requires frequent calibration. So never really took off. But some centers which do nasal nitric oxide and have been doing like the last 10 years still have this kind of measurement with them. Very few in India. In fact, I'm aware of only 1 or 2 centers. There is also a laser absorption diffraction technique which picks up nitric oxide, not again slightly bulkier, costlier technique. So the handheld or really mobile FeNO really took off when the electrochemical technique really was invented. And this is the middle thing that I want you to focus on. So it is portable, fair sensitivity, has a decent response time, and does not require much calibration. And most importantly, like Douglas Adams says, it is cheap. So these are the three techniques and how we are currently using this particular technique. When we speak about FeNO, what is again very important is the amount of nitric oxide is not constant. It also depends on how much air is flowing out of the lungs. So the rate of flow is very important. And most electrochemical sensors, they are calibrated for a flow of around 50 ml per second plus or minus 10%. So flow rate control during exhalation is very important. How do these different commercially available electrochemical sensors, are they interchangeable? To a vast degree, they show a fair degree of concordance within the measurement range, which is typically 5 to 50 is what we're looking at, but most sensors will be able to measure more than that, 5 to 500 say. So they show a fair degree of concordance, but they're not necessarily all pick up the same elevated FeNO. So it's important to know what machine you're using and how much it has been tested worldwide or data is there. Another important thing when you look at FeNO is there is ambient nitric oxide. So it's important for your machine to scrub out the ambient nitric oxide. So when you're calibrating with, say, the chemiluminescence, that will always test what is the nitric oxide in your surrounding environment, scrub that out or remove it in the purpose of calculation mathematically from the amount of nitric oxide that is coming out. For example, here, the NIOX system will ask you to measure the nitric oxide in the inspired air and then scrub it out from calculations when you exhale it out. So this is important. So you need to make sure that your machine is doing this particular thing. Otherwise, it might be measuring ambient, the elevated FeNO may actually reflect ambient nitric oxide as well. When you're measuring nitric oxide, these are other important things. Always nitric oxide FeNO should be done before spirometry. Doing a maneuver itself will change the FeNO. So it should not be done on the same day after spirometry. This is important. And of course, the other things are pretty same. No nitrate-rich foods. The common nitrate-rich foods could be, say, beetroot. So these are things that you need to look at according to relevant dietary patterns and, non-vegetarian foods. So whether, the last 24 hours, you should give them this thing, and that can, interpretation of your test can be influenced by that. And we'll go through how a test is done. I don't know if you can play that. The filter has been placed on top of the probe, and you can see her breathing in first and then blowing out, exhaling for 10 seconds, maintaining it in the green mark, which is the flow rate constant. So that is the amount of flow that should be constant. It should not be too high, not should be too low. And then the sensor will then measure this and give you the output after 1 minute, 1 entire minute. So that is the test. So as you can see, it's a pretty simple test compared to spirometry or even oscillometry. It takes only like a minute to get the result out. The machine is pretty small and portable. So that is these are all the advantages of this particular test, and you'll get an output like this. And there's a particular reason why I've shown you this, but output, we'll come back to that later. Right. So the question is, how do I now interpret this particular FeNO? So most of this data on interpretation came from this cohort of 2,500 patients that was our normal patients with no lung disease that were recruited by for this interpretation and this paper, the ATS interpretation of FeNO levels, which came out in 2011. So people without respiratory disease, they were all, they had measurements of FeNO done. And you can see that for using a cutoff of 26, 81% of patients were actually below that. So why I'm putting this particular figure? So if people with unselected, they had no respiratory disease, the chance of having a FeNO more than 26 is 20% of the time. So you should remember this while interpreting FeNO. Again, this is the upper cutoff. So people with stable asthma, they had an upper cutoff of 47. Again, this was 90% of the time. So this is where the cutoff of 47 or 55 is come off from this particular paper. So based on this, the ATS guidelines kind of gave you this kind of figure. That is for adults. If you have a FeNO of less than 25, that is low. If you have a FeNO of more than 50, that is high. If you have a FeNO of less than 20, that's low for children. If you have more than 35, that is high for children. So different cutoffs for pediatrics and adults. Important to remember these four numbers: 25, 50, 20, 35. So this is essentially a continuous variable which we've now made dichotomous. And there is some price to pay when you make a continuous variable discrete. So this is what you need to remember. So in an ideal world, we like this particular FeNO to be straight related only to asthma, but this is how the actual world will look like, very messy. So these are all the other things that you should consider. Like apart from asthma, there will be some overlap in patients with underlying lung disease, like those patients that Dr. Prince showed. So some history of past exposure of biomass fuel, prior smoking, a family history of asthma. So people with overlap will also have high FeNO. And of course, patients with eosinophilic bronchitis, but not necessarily asthma, will also have high FeNO. Patients who have no airway disease, but just upper airway disease, allergic rhinosinusitis, eczema, polyps, they can also have high FeNO because the epithelium is activated in the lung, but they will not have clinical asthma. And FeNO is also negatively affected by smoking and alcohol. So smoking in the last 24 hours will negate or will suppress the FeNO level as such. Airway obstruction obviously will kind of lower FeNO because it is dependent on the air coming out of the lungs. So if there is a lot of heterogeneity and a lot of flow is not very good, then even, or say during an acute episode of asthma itself, during a mild exacerbation, you might get a low FeNO. We've also spoken about nitrate-rich foods, increasing FeNO, especially viral infections. So people with acute viral exacerbations, specifically rhinovirus exacerbations, have been seen to have elevated FeNO. But other exacerbations, RSV, influenza, actually reduces FeNO. So this is also an interesting observation. Air pollution because of the ambient nitric oxide. If your your probe is not scrubbing out that can again lead to elevated FeNO levels. Of course, male, gender, height, these are physiological. So people with larger lung volume will have more flows and they will have higher FeNO levels than the otherwise. Therapies will also affect FeNO. So oral steroids, inhaled corticosteroids, montelukast reduce FeNO. And of course, doing a spirometry itself will reduce FeNO. So what is the utility? So this is in the background of asthma control in our country. So this is one paper which all of you, most PGs should be aware of. It came out in 2015 in JAPI, predominantly in North India and East India, about 400 patients who are asthmatics. So when they were first interviewed, 75% had no PFT ever done. Or 85% were on some oral steroids with average of around 10 bursts, sometimes in a more, even in a year. Less than 1 in 3 actually used controllers, and majority preferred rescue and oral rescue rather than this thing. So when they looked at what is the control, 0% were well controlled, and only 60% were partially controlled. This is the state of affairs in India. I'm hoping that South India is better than North India, but it's unlikely to be like markedly different. It's likely to be like say 30-40% better, but the data is lacking. And maybe that's one thesis paper for you. So what is the utility then? We can use FeNO to to look at different facets of asthma. One is for diagnosing asthma itself, so which we'll go to one by one. So for diagnosing asthma, what is the role of FeNO? If you look at patients who have normal spirometry, they don't have BDR, but is clinically thinking of asthma, the normal spirometry and absence of BDR does not rule out asthma. So you actually require bronchoprovocation in that instance. But in the absence of bronchoprovocation, if your lab is not set up to do bronchoprovocation, if you do FeNO and if you show a FeNO more than 50, in the appropriate clinical context, that strongly favors a diagnosis of asthma. And that is there now in the GINA guidelines as well in the 2023 version. And of course, other guidelines are also kind of give this conditional this thing. We know that 20% of patients will have a FeNO of more than 25 if you take the clinical context out of it. So you need to put a clinical context. And with this clinical context, if you have a FeNO of, especially which is higher than 50, then your likely diagnosis of asthma is pretty strong. With the caveat that you will likely to miss T2 low asthma. So this is the current ERS algorithm for diagnosis of asthma. This is in pediatrics. So in pediatrics, the flowchart cases, of course, obviously you perform spirometry or oscillometry. And then if the spirometry is normal, then the next step would be to perform FeNO. And if the FeNO is more than 25, if there is significant variability also some ways, which you can show by either doing a PFR variability or by performing a bronchoprovocation, then your diagnosis of asthma is pretty straightforward. If you come to adults, if you have the right symptoms and if your spirometry does not show obstruction and you don't have bronchodilator reversibility, but your if your FeNO is more than 50, then your diagnosis of asthma is established. So these are, the ERS guidelines. And GOLD is also kind of changing it to a conditional recommendation in 2023. So to summarize, in patients who do not have a diagnosis of asthma and they are treatment naive, and that's important, if your FeNO is more than 50, then not only can you make a diagnosis with a fair confidence that it's likely to be asthma, but you can also know simultaneously that T2 inflammation is likely and they are likely to respond to inhaled corticosteroids. However, if the FeNO level is less than 20, it's important to remember that asthma is not excluded. It's possible that the patient has T2 low asthma, but what you can also conclude is that if the patient has asthma, they're less likely to be responsive to only ICS escalation. So that is important. The second point about FeNO is to predict the initial choice of therapy. So when somebody is treatment naive and you made a diagnosis of asthma based on spirometry and symptoms, then what would your first choice be? If the FeNO is high, then obviously it makes sense to give inhaled corticosteroid. But it's also important to remember that a FeNO less than 20 does not rule out response to ICS. So if the treatment naive, you still need to treat them with inhaled corticosteroid. But if they are not responding to that, then there's a strong case of looking at other comorbidities for T2 low asthma. For this prediction of steroid responsiveness, FeNO is much better than spirometry, bronchodilator reversibility, peak flow reversibility, and IgE as a predictor of ICS response. The third aspect of using FeNO is to predict who's going to develop exacerbations. So patients who are on therapy on inhaled corticosteroids, if they have persistently high FeNO levels, then they are at a high risk of exacerbation, and the odds ratio vary from 2 to 6 depending on the paper that you would read. The problem, of course, is that there is no well-established minimum difference for follow-up FeNOs. If you look at the original 2011 paper, or ATS paper, they would say that if a FeNO is more than 50, then you use 20% reduction as a cutoff. Or if the FeNO is less than 50, you use a 10 ppb as a MID, but that is not based on much evidence because that paper did not serially follow, FeNO over time. But if, of course, the FeNO changes significantly over, say 20 or 30, then it's definitely likely to be important. And a lot of work is now happening on severe FeNO, so you're likely to hear more in that space. Third, the fourth component is to titrate steroids. So if somebody's FeNO is low on therapy, do you want to get rid of the dose of steroids? Like if they're on 800 mics of budesonide, do you want to come down to 400? So does the FeNO help in that way? So this is the systematic review of all published papers in this. The problem with these kind of the studies in this space are that they have not selected T2 high asthma specifically. They've just selected all asthmatics. So the predictive power of FeNO comes down. So this is where there is a clear want of papers. So we need to focus on FeNO as a predictor for T2 high asthma alone rather than all asthma. So when you look at FeNO-guided asthma management on major and severe exacerbations, because you've selected unselected patients, the significance just about fails statistical significance. So if you look at this particular point here, it is almost near statistically significant. It's 0.8, but this is just crossing unity 1.02, and this is what the chart is also showing. And similar, the case of using mild to moderate exacerbations also, this is true. But if you look at composite of all exacerbations and treatment failure rates, clearly FeNO-guided therapy is superior, and this is true for the mean inhaled corticosteroid dose when you're using. Say, for example, if your FeNO is low, then you're down titrating. If your FeNO is definitely likely to help that. So definitely some role to titrate inhaled corticosteroids. If you look at current guidelines, however, because of this uncertainty, they have said that do not use FeNO to completely, to follow patients. And the data is more robust for children compared to adults. So in children, of course, more data where you can use FeNO to titrate ICS dose, and you're worried about ICS dose more in children than in adults. So definitely, but in adults, the data is not so robust. Having said that, there are caveats to the published paper, and this is what you should remember. So GINA advises against using FeNO for guiding therapy, but the other guidelines say you can choose monitor and putting into the overall context. So you would likely to have these 4 scenarios. So one is your symptoms and asthma scores. If you're using whatever ATAC, ACQ or whatever. So if your asthma is clinically well controlled, patient is not having much exacerbations, and the FeNO is low, then you can use your clinical judgment and actually step down your amount of inhaled corticosteroid and follow up these patients. You're likely to be doing well here. However, if the patient's symptoms and exacerbations are low and the FeNO is high, you cannot use FeNO to titrate therapy here. You should probably not be up titrating the inhaled corticosteroid here, because we know that 20% of patients can have high FeNO. One. Second is, it is possible that they're having other comorbidities which are elevating the FeNO, say rhinosinusitis, etc. So you need to look at the comorbidities also and need to see other causes of elevated FeNO are there before you consider adjusting your ICS dose here. If your symptoms are high and the FeNO is low, then this is likely to be either like confounder, a false cause of a cause of low FeNO test wise, or because they have T2 low asthma, maybe coexisting GRD, obesity, OSA, etc. This is what you need to look at here. But if the symptoms are high and the FeNO is high, then you need to step up therapy. You need to make sure the compliance is good, the technique is good. And once that is done, despite all that, then they will fall into the severe asthma category, which is when they become a candidate for biological. So this is how you'd use FeNO during follow-up. And in context of that, when I spoke about the 4th chart, monitoring adherence also is something that FeNO can help you with. We know that 17% of asthmatics can be labeled difficult to treat asthma, but actually only less than 4% will have severe asthma. And the gap between these two is adherence, technique, the inhaler technique, and the correct dose of therapy. So these are the 3 things in which basically FeNO can do. There is something called a FeNO suppression test. So there is some published data about this. So you give patients a 5-day course of high-dose inhaled corticosteroid, which typically is at least 800 mics of budesonide and 500 mics of fluticasone. And you repeat the FeNO on day 0, 1 and 4, 5. And if you show a suppression, that is technically a 42% fall in FeNO, then these are patients who are steroid responsive and less. And the reason they were difficult to treat was because they were either not adherent or the technique was not right. So this is something that can help you objectively as well before you go to biologicals in these patients. And finally, the most important role of this thing is in T2 high asthma. So to phenotype severe asthma and choice of biologicals, which we'll focus on the next slide. So for T2 high asthma, strictly speaking, the way to define T2 high would be what is happening in the airway epithelium. So is the gene for periostin, serpin-2, and CLCA1 elevated? But however, this is not something that you can do in every patient because you require an airway sample and it's invasive, and obviously it is a research tool. So and this is those genes being elevated will then drive all this particular inflammation in patients with asthma. So instead of that, we have a host of other tests which we use as surrogates of this particular the gene expression and consequent inflammation. We use these particular tests as surrogates of this. So the surrogate, that it's important to remember what these surrogates are actually representing. For example, if you can have atopic asthma, which is not necessarily eosinophilic asthma, but a lot of them will overlap, which is what the circle is showing. And you can have IgE elevation, not necessarily in everyone. So we know that only 50% of patients with T2 high asthma will have elevated IgE, but patients with IgE can also have elevated IgE due to non-atopic mechanisms. So that again, IgE does not completely overlap with atopy. So that is again important. And we know we use, or the conventional tool for T2 high is sputum eosinophilia, which is we use a cutoff of 2% or 3% depending on the study. And we know that it'll only pick up 40% of those with gene expression. The lab has shown this particular gene expression, only 40 to 50% of them, this sputum eosinophilia, which we consider reference, will pick up. Using serum eosinophils or using FeNO will again only pick up 70 to 80% of those with sputum eosinophilia. So there is a gap between this particular thing and this particular thing, which is why clinical interpretation becomes very important. And serum periostin performs very, of the lot. Serum periostin is, functions relatively poor. It has more correlation with lung function rather than, in T2 asthmatics rather than exacerbation. So again, so what particular part of the puzzle are you having access to? And within those particular, groups, what is your patient actually then? T2 high asthma, is your patient having aspirin exacerbated respiratory disease, or is the patient having atopic asthma? Again, important, or whether the patient is having eosinophilic asthma, because your choice of therapy is going to totally differ based on where your patient is actually. So overall, this is where we need to group patients broadly, T2 high and T2 low, having realized that these are the issues that are there at the background. And how is FeNO going to help you in this particular classification in the context of these particular things? Purely because it is better than not doing. So you need more information to categorize patients better. So if you use only spirometry, asthma control test, and examination, you're likely to only say, 4% of patients will have T2 in this particular study. 4% of patients had T2 high and only 28% had intermediate. So these are the patients you would classify conventionally, 32% as T2 high. Whereas if you use FeNO as well, you now classified 44% as T2 high. Therefore, these patients are now eligible for more therapies, especially if they are uncontrolled. The problems, especially with sputum eosinophils and serum eosinophils, also make FeNO a good tool. So sputum eosinophil count, even though we consider that as a reference, it's more invasive, requires a nebulization. There are infection concerns, especially after COVID. Sputum induction is not, universal. Half the patients may not, in our setting, produce a sputum sample. In research settings, 90% do, but in our setting, 50% don't. The sample, if produced, also must be technically adequate. And then most importantly, sample processing has to be standard with the inverted microscopy, which most labs do not do, including mine. So we need, better test. So the only other alternative, of course, is peripheral eosinophil count. And however, we know that peripheral eosinophil count is not a static thing. It's opposed to so many things. So even without therapy, peripheral eosinophil counts over time need not be the same. So only, persistent eosinophilia will be seen in very few patients, whereas eosinophilia can be going up and down. And then we know that in a country like ours, this peripheral eosinophilia can reflect several other things as well, like parasitic infestations, etc. So where do the guidelines stand on using of, FeNO in T2 high asthma? So clearly, yes, when you diagnose asthma and your patient is having severe asthma, you not only look at peripheral eosinophilia and sputum eosinophilia, but you also look at FeNO. And if the FeNO is more than 25, then you're labeling patients as T2 high asthma. And if they have less than 25, then you can label them as T2 low asthma. So that is, the guidelines have agreed that. And in terms of choice of therapy, of course, this is going to help. It helps in particular subsets of T2 high asthma, not in all T2 high asthma therapies. For example, if you have, a FeNO of more than 20 or 25, and you've labeled patient as having T2 high asthma, then you need to look at whether they are candidates for they're anti-allergic therapy or the candidates for interleukin 4R. For interleukin 5 therapies, FeNO is not a tool. This is primarily based on either peripheral eosinophilia or sputum eosinophilia in the context of exacerbations. So this only helps you in dupilumab or in omalizumab choice. So here a choice of FeNO of 20 is used. Again, same here as well. So finally, there is an upcoming role of FeNO in other respiratory diseases like COPD and bronchiectasis as well. So there is, as opposed to testing peripheral, we know there are a lot of papers, hundreds of papers, this way, that way. Today you read, you'll find, withdrawal of corticosteroids is fantastic in COPD. The next day it'll say it's a bad idea. So whatever, we know that overall, up to a third of patients with COPD can have peripheral eosinophilia, using a cutoff of more than 150 or 300, and they may be having a higher exacerbation rate if you withdraw the inhaled corticosteroid. Using FeNO, you can actually separate these patients much better, whether they're having a prior asthma history overlap or not. FeNO can give you better, no, obviously not 100% information, but it can give you a better separation between these particular subgroups because of the type of inflammation, which is slightly different. The other more important, interesting paper, which is just this issue of respirology, is that the fluctuation in FeNO actually can help you guide COPD management. So those frequent exacerbators, when this FeNO starts going up, it actually tracks before an exacerbation of COPD. And that is something that this was there just in this paper. So more works needs to be done in this context. Finally, about FeNO in bronchiectasis. So that of course, nasal FeNO is a role. It can be done in the same machine, the Neox Viro machine, and we use a specific nasal catheter, and that will basically only look at nitric oxide coming from the upper airways. And this is how the graph looks like. So the reason to do this particular test is basically because FeNO is low in patients with primary ciliary. Nasal FeNO is low in patients with primary ciliary dyskinesia. There are two important caveats to this particular thing. And when you say low, it usually means less than 100. When you say high, typically normal nasal FeNO is several hundreds, like it's 600s. Here, for example, you can see the low level was 70 or in one of my patients. So you can, the caveats are, one is you should rule cystic fibrosis, which itself can be a cause of low nasal FeNO in 1/3 of your patients of CF. The other thing is they should not have any active rhinosinusitis. So these are the two important caveats you should do. And then you should always repeat it in two settings at least before you can label it as ciliary dyskinesia. And how do the guidelines say? I'm sorry, it's not projecting well, but I just wanted to put one particular slide on what the guidelines say. So this is the ERS guidelines. There are two, like the ATA statement on ERS statement on primary ciliary dyskinesias, and both are slightly different. But they don't differ on the nasal nitric oxide. What they differ on the high-speed video microscopy. So in the ERS guidelines say that you should, at step 1, when you think of primary ciliary dyskinesias, you need to do the nasal nitric oxide and high-speed video microscopy. And if that is showing both are concordant, then you straight go to the genetic test to make the diagnosis of PCD. If they are discordant, then you go through electron microscopy. And but nitric oxide is easily available because you have the device, and it can be done with the same way FeNO can be done. So it's easy to do. So that's how it's accessible to us, as opposed to say genetic testing and electron microscopy and high-speed video microscopy. So this is how this thing. So take-home messages: FeNO offers a new accessible window to airway inflammation. There is a chance of misclassification if you interpret it alone. So you always have to interpret it in the context of other symptoms and composite T2 inflammation scores. And you use the cutoff of 25 and 50 in adults and 20 and 35 in children. And it has a role in diagnosing T2 high asthma, predicting exacerbations, and helps in initiating biologicals. Thank you.
Thank you, Dr. Srinivas. As usual, it was a wonderful, lucid lecture, so that everyone can understand that the pace at what you talk and deliver the things. So any questions from the audience? Because this is one of the, we can't call it as novel, Like we used to say new FOT, this is also there. The biology of nitric oxide is there everywhere. So any questions?
Sir, can you again explain how the, the inflammation leads to excess of nitrous oxide in the
So
the-
basic biology. So it's that basically nitric oxide is already there. It is constitutive at a low level because it's involved in the vasodilatation of the smooth muscles. It's involved in endothelial function. So it's always there. So constantly everybody has nitric oxide coming on from the upper airway and the lower airway because the epithelial maintenance requires that. And also there is some neuronal transmission because of the nitric oxide. From the non-sympathetic parasympathetic pathway, it's in the nerves as well. So these are the constitutive things, but they produce a very small level of nitric oxide. When inflammation happens, the macrophages and neutrophils also bring in the inducible nitric oxide synthase along with them. So all the granules will have NOS. So that will produce a burst of nitric oxide because of the large amounts of inflammatory cells in the epithelium now. So you're going to have higher, much higher levels as opposed to the usual 2 to 5 that is there. So that is how there is more airway nitric oxide because of the inducible nitric oxide.
Thank you, sir, for the wonderful presentation. And our associate professor Vimal sir will now honor the guest speaker with a memento and a certificate for appreciation, token of appreciation.
Interestingly, Dr. Srinivas Center is one of the few centers who is having nasal nitric oxide in Tamil Nadu, I think. Yes. Yeah. So that's one of the screening tests for primary ciliary dyskinesia.